Welcome to the Deep Dive. If you're thinking about practicing pharmacy here in Canada, now, you've probably heard of the PEBC Canada Handbook.
Oh, absolutely. It's pretty central.
Yeah, so today we're basically going to try and unlock its secrets for you. Think of this as your, guided tour through the really essential stuff you need for the Pharmacy Examining Board of Canada's whole certification process.
Exactly. And it's more than just facts, right? This handbook, it's really a strategy guide. It's packed with the knowledge, the approaches you'll need for both exams, the evaluating exam, the EE, and the qualifying exam, or QE.
So our mission, really, in this deep dive is to pull out those key insights.
Yeah.
We wanted to give you a solid feel for what that PBC journey actually looks like, clear up the exam formats, and really pinpoint those crucial knowledge areas, the ones that can make a difference.
Definitely. And the handbook covers, well, pretty much everything. We're looking at excerpts from all over the exam overviews, how to prep, pharmacotherapy, that's how drugs treat diseases calculations, which are critical.
Right.
Medicinal chemistry, so the science behind the drugs, pharmacy practice itself, law, ethics, biostats, clinical biochemistry, microbiology. No. Oh, and pharmacokinetics, pharmacodynamics, how drugs move and work in the body.
Wow, okay. It's comprehensive.
It is, and OTCs, compounding, disease states, side effects, ADRs, finding drug info, talking to patients, exam strategies, even practice questions and a mock exam. It's all in there.
Okay, let's start unpacking it then. Maybe begin with the basics. PBC itself. What is it, and why do these exams even exist?
Right. So the Pharmacy Examining Board of Canada, PBC, it's the national body. Their job is basically to make sure any pharmacist licensed here meets the professional standards, for safe and effective practice. They're kind of the gatekeepers.
Gatekeepers, I like that. And the exams?
The exams are there to check a few things. Your knowledge, obviously the science, the clinical side, your clinical reasoning, so problem solving, and also your practical skills, patient care, communication, that sort of thing.
Okay, so two main exams, EE and QE. Well, what's the big difference in how they're set up?
Well, the evaluating exam, the EE, that one's purely multiple choice questions, MCQs only. So it really tests your foundational knowledge, recall, applying those core concepts quickly.
Got it. All MCQs.
Yeah. But then the qualifying exam, the QE, that's different. It has MCQs and something called an OSCE, Objective Structured Clinical Examination.
OSCE, right? That sounds more hands-on.
It is. That's where you demonstrate your practical skills, in simulated patient scenarios, like acting things out almost.
Okay. And what scores are we talking about? What do you need to pass?
For the EE, you're generally looking at needing around 65 to 70% to pass, something in that ballpark.
Okay.
For the QE, it's a bit lower per part, around 60 to 65%, but you need to pass both the MCQ part and the OSCE part separately.
Right. Got to clear both hurdles. Now, for someone listening, maybe thinking about this path, what are the first steps? Eligibility, registration.
Okay, so first things first, especially if you trained outside Canada, is credential verification. That's a big step. After that, everyone applies through the PEBC online portal. There are fees, of course. For both exams together, it's roughly $1,500 CAD, give or take.
Right.
And then you schedule your exams. They usually run them 3 times a year, spring, summer, and fall.
And language proficiency, that's important too, isn't it? Especially for international grads.
Oh, absolutely crucial. If you are trained internationally, you need to prove you're proficient in English or French. So tests like IELTS Academic, CELPIP General, or TEF Canada, they have specific minimum scores, and the results are only valid for 2 years.
But there are exemptions.
Yes, there are. If you graduated from an accredited pharmacy program in Canada, the US, UK, Ireland, or a few other specific countries, you might be exempt. You'd need to check the specifics with PEBC.
Okay, so let's say you're registered. How do you even start preparing for exams this big?
Yeah, preparation is key. You need a plan. The handbook suggests a study plan spanning about 3 to 6 months.
3 to 6 months, okay.
And resources are vital. The official PBC blueprint is #1 that tells you exactly what's covered. Then there are popular study aids like RX Prep, Toronto Notes, and really important practice exams. You need to simulate the real thing.
What are the common stumbling blocks people face? And how do you get over them?
Time management is huge. Just fitting it all in. Timed practice tests really help with that, getting the pacing right. Complex MCQs can trip people up too. A good strategy there is, elimination. Knock out the obviously wrong answers first.
Good sense.
And for the OSCE, nerves are a big factor. It's performance anxiety, really. Doing mock exams with peers, practicing those scenarios, that helps build confidence a lot.
Are there specific resources the handbook really emphasizes? Like must-haves?
Well, the PBC prep guide itself, obviously, and the CPS, the Compendium of Pharmaceuticals and Specialties, that's a major reference. Online, the official PBC website is your go-to. The Canadian Pharmacists Association site is also very useful.
And what if? Well, what if you don't pass the first time?
It happens. PEBC allows up to 4 attempts per exam.
4 attempts, okay.
Yeah, so there are chances. But honestly, with the cost and the time involved, you really want to aim to pass on that first try. Thorough prep is the best approach.
Right. Makes sense. And once you get that PBC certification, is it valid forever?
The PBC certification itself, yes, it's indefinite. But, and this is important to actually practice, you need a license from the province where you want to work.
Ah, okay. Provincial license.
Exactly. And those licenses need regular renewal. The rules for renewal can vary a bit, province by province.
Okay, good distinction. Let's shift gears a bit. I hear there are updates for the 2025 exams. What's changing?
That's right. PBC does update things to keep pace with practice. And yeah, for 2025, there are some key changes people need to be aware of.
So what are the big format changes?
Okay, biggest one for QE Part 1. No more short answer questions. SAQs are gone. They actually stopped those back in 2023. So QE Part 1 is now 100% MCQs.
All multiple choice for Part 1 now.
Oh.
Interesting.
Yeah. And the OSCE QE Part 2, it's expanded. It's now 16 stations, up from 12 or 14 before. Plus, there's more emphasis on things like virtual care, addiction medicine, and counseling diverse patient groups.
16 stations, wow. And more focus on current issues like virtual care. Makes sense. What about the content within the questions?
Well, there's definitely a bigger push towards case-based MCQs. They make up about 70% now.
70%. So really applying knowledge to situations.
Exactly. It emphasizes clinical reasoning. Also, reflecting practice changes, things like pharmacists' universal authority for COVID, RSV, and travel vaccines that expanded scope is now part of the assessment.
That's a big shift in responsibilities being tested. Are there completely new topics showing up?
Yes, several. Things like GLP-1 agonists, for diabetes and weight management, they're huge now. Psychedelic therapies are emerging, dosing considerations for obesity, and, as I mentioned, virtual care practices.
Okay, lots of new ground to cover. So with all these updates, what's the key advice for studying for 2025?
Number 1, use the latest PBC blueprint. Always. That's non-negotiable.
Right.
Then, given the focus on cases, really prioritize case-based learning. Work through scenarios. Practice applying your knowledge.
Makes sense.
And with virtual care being bigger, maybe practice those kinds of interactions too. Think about how you'd counsel someone over video, for example. And just stay informed on new drugs, new guidelines. Things are always changing.
Good advice. Okay, let's zoom in on the evaluating exam, the EE. We know it's all MCQs, but tell us more about its structure.
Right. The EE, it's computer-based, taken at a testing center. Its main job is to check your foundational knowledge in pharmaceutical sciences. So recall, application, problem solving, the basics, but applied.
And you pass this one before the QE, right?
Absolutely. It's the prerequisite. Can't do the QE until you've passed the E.
Yeah, and the MCQs themselves, are they just simple recall?
Not entirely. They use a single best answer format. 4 options, 1 clear best answer. Some might be straightforward recall, yeah, but many are designed to test critical thinking. They often include case scenarios, even in the EE, to see how you apply that knowledge.
Okay. And how's the content split up? What subjects are covered most?
It's broken down into domains. Pharmacology is the biggest chunk, maybe 25–30%. That's how drugs work, mechanisms, etc.
Right.
Then pharmacy practice, about 20–25%. Think law, ethics, dispensing, counseling. Medicinal chemistry and pharmaceutics. So drug structure and formulation, they're each around 15–20%.
Yeah.
And finally, biostatistics, that's about 5–10%, applying stats to pharmacy data.
Got it. Let's dive into one of those big areas then, pharmacology. What are the absolute fundamentals people need to grasp?
Okay, pharmacology. At its core, it's about how drugs interact with the body and how the body handles the drugs. 2 main branches, really. Pharmacokinetics, or PK.
PK, right.
That's what the body does to the drug. Think ADME. Absorption, distribution, metabolism, usually in the liver, involving those CYP450 enzymes you hear about.
Ah, yes, the CYPs.
Exactly, the liver's processing system. And then excretion, mostly via the kidneys. Understanding drug half-life, how long it takes for half the drug to leave the body, that's also crucial PK.
Okay, ADME and half-life, that's PK. What's the other side?
That's pharmacodynamics, or PD, what the drug does to the body.
Right, the drug's effect.
Exactly. Key concepts here are agonists versus antagonists. Agonists activate receptors like a key opening a lock. Antagonists block them like a key that fits but won't turn, blocking the right key.
Good analogy.
Also important is the therapeutic index, basically, how safe the drug is, the gap between effective dose and toxic dose, and the dose-response curve, showing how effect changes with dose.
And knowing the different classes of drugs seems vital, too. Can you give a couple of common examples?
Sure, like beta blockers, metoprolol, for instance. They block adrenaline's effects, slowing heart rate, lowering blood pressure. ACE inhibitors, like lisinopril. They inhibit an enzyme, relax blood vessels. SSRIs, like fluoxetine for depression, they affect serotonin levels in the brain. Understanding these mechanisms is key to predicting effects and interactions.
Speaking of effects, what about the unwanted ones? Adverse drug reactions, ADRs? How are they categorized?
Generally, two main types. Type A reactions, A for augmented. These are predictable from the drug's action, usually dose-dependent, like too much warfarin causing bleeding.
All right, predictable.
Then type B for bizarre or idiosyncratic. These are unpredictable, often immune-related, like a penicillin allergy, not related to dose in the same way. The handbook has a case on statin muscle pain, which is typically type A linked to dose, and you monitor certain enzymes like CK.
Got it. And drug interactions, another huge area for pharmacists. What are the main types there?
Again, broadly two types. Pharmacokinetic interactions, one drug messes with the ADME of another. The classic is grapefruit juice inhibiting CYP3/4 enzyme, boosting levels of some statins.
The grapefruit effect.
That's the one. Then there are pharmacodynamic interactions. Here, two drugs have effects that add up or oppose each other at the target site. Like, taking an NSAID with warfarin increases bleeding risk, even though they work differently.
Okay, that's super important to track. Let's switch gears again, pharmaceutical calculations. Why is this area so heavily emphasized?
Oh, it's absolutely critical. Accuracy here is paramount. Errors can cause serious patient harm. It's not just for the exam, it's fundamental to safe practice every single day. You just have to get it right.
No kidding. What kind of basic math skills are essential?
You need a really solid grasp of the basics. Fractions, decimals, percentages, ratios, proportions, and unit conversions are huge within the metric system, and between metric and household measures like teaspoons to milliliters.
Right. And dosage calculations are core, obviously.
Yeah.
What kinds of things are involved?
Well, calculating the number of tablets or capsules, obviously, but also liquid medications converting a prescribed dose in milligrams to a volume in milliliters based on the drug's concentration. The handbook has an example with amoxicillin suspension, figuring out the volume needed.
Okay. And what about IV calculations? They can seem a bit more intimidating.
They can be. You need formulas for flow rate volume over time. And drip rate, considering the volume, the drop factor of the IV set.
Drop factor.
Yeah, how many drops make 1 ml? Different 5e sets have different drop factors. You need to know that for the calculation. And figuring out remaining volume in a bag.
Are there specific tips for tackling these on the exams?
Definitely. Always, always check your units. Be consistent. Hours versus minutes is a common pitfall. Remember, drip rates for gravity IVs need to be whole numbers, no partial drops.
Okay.
Memorizing common drop factors helps. Practice time conversions. And double check everything. Especially with IVs, accuracy is just life or death, potentially. Also, know that pumps are usually ml hour, while gravity drips are drops minute.
What are the mistakes people tend to make most often?
The handbook points out a few common ones. Forgetting unit conversions. Using the wrong drop factor. Simple decimal point errors. Or rounding too early in a multi-step calculation that can mess up the final answer.
Okay, good warnings. What about pharmacokinetic calculations? Do those come up too?
Yes, they do. You need to understand parameters like half-life, volume of distribution, how widely the drug spreads in the body, and clearance, how quickly it's removed.
Right.
And you need the formulas to calculate things like maintenance doses, loading doses, that initial higher dose clearance rates, and AUC, the area under the curve, which shows total drug exposure. The handbook gives you the formulas, units, and examples.
Okay, let's move into medicinal chemistry. This sounds quite scientific. What are the key things to know for PBC?
It is science heavy, but it's about drug design. You need the big picture of drug discovery and development. Target identification, finding hits, optimizing leads, preclinical studies, then clinical trials. It's a long process.
Right, takes years. What about structure-activity relationships, or SAR? What's that?
SAR is basically how changes in a drug's chemical structure affect what it does biologically. So things like functional groups, alcohols, amines, the 3D shape, or stereochemistry, the molecule size. The handbook uses beta blockers and penicillin structure as examples of how specific parts are crucial for activity.
Okay, structure equals function, essentially, and pharmacophores.
A pharmacophore is like the minimum essential part of the structure needed for the drug to work. The key features for interacting with the target. Think of the core structure of opioids, or the key part of an ACE inhibitor like captopril. Computer-aided drug design, CAD, uses this idea to help design new drugs.
And functional groups, are there specific ones we should recognize?
Yeah, recognizing common ones helps, like the carboxylic acid in aspirin linked to its anti-inflammatory action, or amine groups in drugs like amitriptyline affecting nervous system targets, hydroxyl groups like in ethanol affecting solubility. Knowing these helps predict properties.
Drug metabolism came up under PK. How does medicinal chemistry view it?
From a chemistry perspective, it's about the reactions. Phase I often involves CYP450 enzymes making small chemical changes, oxidation, reduction. Phase II is conjugation sticking on a larger molecule, like glucuronic acid using UGT enzymes, to make the drug easier to excrete. Understanding CYP enzymes like 3A4 and 2D6 is vital because so many drug interactions happen there.
Right, those enzyme interactions again. What about enzyme inhibition?
Important concept, two main types. Competitive inhibition. The drug blocks the enzyme's active site, competing with the normal substance. Statins blocking HMG-CoA reductase is a classic example.
Okay.
Non-competitive inhibition. The drug binds elsewhere on the enzyme, changing its shape so it doesn't work as well. Methotrexate inhibiting dihydrofolate reductase works like this.
Yeah, finally for medchem, receptor theory.
Yeah, fundamental. Receptors are proteins drugs bind to, different types. GPCRs, ion channels, nuclear receptors. Drugs can be agonists, they bind and activate, like morphine on opioid receptors, or antagonists, they bind but don't activate, just block, like naloxone blocking opioid receptors.
The handbook uses case studies here too.
Yes, really good ones, like the development of imatinib for CML chronic myeloid leukemia. It's a prime example of targeted therapy, designing a drug to hit a specific abnormal protein, BCR-ABL, that drives the cancer. Revolutionized treatment.
Wow.
And the penicillin story, of course. Fleming's discovery, Florey and Chain's development, it shows the whole process and the massive impact antibiotics had. Really illustrates the power of medicinal chemistry.
Okay, great examples. Let's bring this all together now with pharmacotherapy principles. This is about actually using the drugs, right?
Exactly. Pharmacotherapy is applying all that knowledge, PK, PD, med chem, to treat patients. Key principles involve understanding the drug's time course, figuring out the right dose loading versus maintenance dosing frequency. The therapeutic window is crucial here, that sweet spot between effective and toxic. And therapeutic drug monitoring, TDM, where we measure drug levels in patients to optimize therapy, that's a direct application of these principles.
We talked about drug classes before. How are they used here?
Well, classifications help organize treatment. Knowing the mechanism of, say, ACE inhibitors or beta blockers or SSRIs tells you how they'll work in treating specific diseases like hypertension or depression. It guides therapy choices.
And disease-specific therapy is a big part of the exams.
Huge. You need to know the standard approaches for common conditions, like hypertension first-line choices often depend on the patient. Could be a thiazide, ACE inhibitor, ARB, calcium channel blocker, or asthma COPD using inhalers. Diabetes starting with metformin usually. Hypothyroidism with levothyroxine, heart failure, high cholesterol, all covered.
And treatment isn't just guesswork, right? It follows guidelines.
Absolutely. Evidence-based guidelines are key, from organizations like Canadian Diabetes Association, Hypertension Canada, IDSA for infectious diseases. They recommend diagnosis, step-by-step treatment, monitoring. Applying these guidelines correctly is a major skill tested.
So when choosing a drug for this specific patient, what factors come into play? And what about monitoring?
Lots of factors. Patient's age, weight, other conditions, comorbidities, potential drug interactions, cost, adherence, likelihood. It's very individualized.
Right.
Once started, monitoring is essential. Is it working? Any side effects? The handbook actually has detailed tables showing what to monitor: baseline tests, ongoing checks, target values, toxicity signs for many drug classes, anticoagulants, cardiovascular drugs, diuretics, statins, insulin, methotrexate, digoxin, opioids. Lots of them.
Wow, that sounds incredibly useful. Are there special considerations for specific groups, like kids or older adults?
Definitely. Pediatrics often needs weight-based dosing, and some drugs are avoided, like tetracyclines in young kids. For geriatrics, the mantra is often start low, go slow because of potential changes in kidney or liver function.
Start low, go slow. Makes sense.
And pregnancy requires careful consideration, preferring drugs with better safety data, like category A or B. The handbook uses case studies for this too, like choosing an ACE inhibitor for a diabetic patient with hypertension because it protects the kidneys. Plus, practice questions covering all sorts of scenarios.
This has been, wow, a really thorough look at just some key parts of the PBC handbook. It's clear becoming a pharmacist in Canada requires a very broad, very deep knowledge base.
It really does. Key takeaways. You've got to master PKPD, nail the calculations, understand the medicinal chemistry, and critically, stay current with pharmacotherapy guidelines. Drug interactions, patient care principles, they're central. And with practice changing, staying updated on exam format changes and really honing those case-based reasoning skills is crucial for success.
Absolutely. Which brings us to a final thought for you listening. Pharmacy practice is evolving. Pharmacists have more responsibility now, immunizations, virtual care. How do you think the PBC exams will keep adapting? What future skills or knowledge areas might become even more important for pharmacists in Canada? Something to mull over.
Definitely something to think about. And for those of you preparing or just curious, really dive deeper. Use the official PBC blueprint, explore Canadian guidelines, practice with case studies. This deep dive, it's really just scratched the surface. Continuous learning is just essential in this field. It never really stops.